I'm Dr. Jamaluddin. Based on my observation and my personal experience, I have developed a new outstanding technique for squint surgery. I called it myectomy or sutureless technique. I'm working in 6 months before in Jizan Beach Hospital. The aim of it to go beyond the common and explain and discuss our technique and to compare it with the old or the conventional one. There are some rules in medicine that we considered taboo, and we didn't discuss it. Just a rule, it's about in ophthalmology, about squint surgical rule and guideline, either 1 millimeter for every 5 degrees of squint you have to correct, and so. Also the term and ocular movement, like an antagonist, agonist, synergist, and so, it have to discuss more. There's also laws of ocular mobility, like Sherrington law, which is reciprocal innervation, and Herring law. Also, it has to be re-updated. The surgical squint technique mostly the traditional one, depend on the mechanical action of the eye, mechanical action of the muscle, and we change it by resection and recision. And that explains the rule of the movement of the eye. I think the eye is not a machine, it's not a car. You have to think in other way. I suppose there's a compass-like center at the eye, at the ocular eye, that controls the eye movement. Or there is a neurological control, supranuclear control. Or maybe, and this is most, we find it's a neurologic supranuclear control. Background, how I start by this technique. I start like when I work on inferior oblique, myectomy, and I find it after time it's reattached. That's the beginning idea. Then I start by adjustable suture. I do adjustable suture. I found next day it's not necessary to readjust it, especially for recision muscle, and you find the eye motility is very good. What's about the rule which I found it? I found some rule. First, you have to evaluate after every step of operation. You have to evaluate the ocular motility and the eye movement. I work under local anesthesia. Second, you have to cut the muscle and do myectomy, either over insertion, 1 millimeter from insertion, or 2 millimeter from insertion. That's depend at the squint degree. You have to do you have to do more dissection if the squint degree is very high. Also, in some case, I put tractional suture in the direction which I need to the eye move to it for either 7-day or 12-day and assisted. I found in the last edition of this book, Step by Step, Squint Surgery Technique by Dr. Parasad William, that he said there has been steady increase in knowledge of supranuclear pathway that control eye movement, including the pathway in the brainstem and cerebellum and the connection. That support what I work in it. So what about my technique? I think it's a new way and new revolution of ophthalmic technique, because it's simpler, easier, require less time, not more than 15 minutes. You can do it, only myectomy, and evaluate the case, and you finish. Small incision also, not more than 8 or 10 millimeter maximum. Local anesthesia, subconjunctival anesthesia around the muscle only, and it's enough, no pain. Many people feel some discomfort. We give him as a sedation, some sedation. Except for children under 12, I do GA, under GA, light GA, and let them at the end of surgery to wake up to see the eye movement, maybe under fentanyl or so. Side effect is very minimal, no serious side effect and complication, because you didn't do suture. More efficient result. So what about my technique? I got documented 74 cases. Primary case, exo and ESO, and some secondary case reoperated again. 34 of them performed in Bish General Hospital, and the rest in Libya. I lost too many cases before, 10 years before, in my city, Homs, Syria. Age between 6 till 70. Observation start after operation and continue till 1, 2, maybe 3 years sometime. What's the technique? What the result is? After I do myectomy to recess for medial rectus or lateral rectus and leave it as it is, there is no need, I find there is no need at all to reinsert the muscle, because the eye will balance directly during operation. You find that the eye, after you do myectomy, you find that the eye balance by itself and takes the alignment the straight way. And the muscle will also adjust by itself and reinsert as soon as the motility require. That we didn't disturb or didn't disturb the eye motility. Leave it as it is. So some cases, I have many cases. 9 cases of esotropia less than 20 degree, refraction less than +3, either both or medial rectus myectomy. It depends on the case and evaluation of the case. Degree corneal reflex, bicorneal light reflex. Improvement is good, 100%. 12 case esotropia, 35 degree, refraction less than +1, both medial rectus myectomy, 1 over insertion and 1 millimeter from insertion. Also improvement 25. I have also a case of 10 case, more than 45 corneal light reflex, refraction less than 3, +3. Medial rectus, or both medial rectus myectomy, 1 millimeter from insertion and 2 millimeter from insertion. 15 case of exotropia, more than 50 degree. refraction plus minus 4. Both lateral rectus myectomy, 2 millimeter and 1 millimeter either from insertion with more. I do more dissection because I found at the end of the operation it's not alignment very well. I do more dissection to the muscle to go back. Improvement 20%.
Can you conclude, doctor?
Yes. 5 case residual paralysis, 6 nerve, palsy 16 degree. Okay. I have 2 cases of inferior oblique overaction that's usually done in the left eye myectomy 2.5. This is the case. This is before and this is after. This is 2 years before. Also, this is here in Saudi Arabia. Exotropia, bilateral exotropia, this is after. This is crossed fixation esotropia. Crossed fixation myectomy only for one eye, for medial rectus. This is reoperated. She done operation before. She had exotropia. I do bilateral myectomy, and this is the result. This is the last patient. This is, I put a suture because I fear in the beginning to lose the muscle. I put the suture and then I remove it. This is amblopic eye. Also, this is before and after. CT scan found that ocular muscle after operation will very soon insert, you find it, to the sclera in a new place and adjust by itself, and the eye will balance also. This is CT scan after operation. This is the first patient I do it in Saudi Arabia. It's bilateral exotropia. This is CT after operation directly. You see lateral rectus, little hematoma in it. The muscle is reinsert by itself. One day I have to reoperate it for patient which I do it. I found the muscle that reinsert with fibrotic tissue. And I do myectomy to it and make a fixation, suture fixation for him. This is after operation. This is CD if you want to see after 6 months. The eye motility, can I do it, this CD?
I don't think we can do that, because you have 5 minutes over your time.
Okay.
Can you please conclude?
Yes. This is, okay. This is before and after, old cases in Libya, it was in Libya. Also, this is before and after. This is also, you find here myectomy, I do myectomy. This is after operation, the muscle, the lateral muscle, bilateral exotropia. This is also after operation. This is bilateral exotropia. This is after, it has video also to see the retraction. Conclusion, the cosmetic improvement is very good, more than traditional one, about 85 till 95. Binocular vision is improved in young children, more than 45. All patients showed improvement, no permanent double vision. This is my city homes. This is 212, and this is now. Okay, thank you.